Sepsis is a dysregulated host response to infection leading to life-threatening organ dysfunction. For the NCLEX, you must move beyond this definition and into immediate, prioritized action. The exam will not ask you to simply define sepsis. It will give you a scenario and expect you to act. Let's consider a classic exam presentation. An older adult patient with a urinary tract infection who now has a heart rate of 125, a respiratory rate of 24, a temperature of 101.6 degrees Fahrenheit, and is newly confused. Your brain must immediately scream sepsis. While the systemic inflammatory response syndrome, or SIRS criteria, are still sometimes referenced, clinical practice and newer exam questions lean towards the qSOFA score, which looks at 3 key bedside indicators: a respiratory rate of 22 or greater, altered mental status, and a systolic blood pressure of 100 or less. If your patient has 2 or more of these, you must escalate care immediately. This is a common test question, forcing you to differentiate a localized infection from a systemic crisis. The most critical knowledge you can have for the exam is the Surviving Sepsis Campaign's Hour 1 bundle. Think of it as your script for the first 60 minutes. First, you will measure the lactate level. A value above 2 millimoles per liter indicates tissue hypoperfusion and is a major red flag. Next, and this is a classic NCLEX trap, you must obtain blood cultures before administering antibiotics. Giving antibiotics first can skew the culture results and prevent identification of the specific pathogen. The exam loves to test this sequence. After cultures are drawn, you immediately administer broad-spectrum antibiotics. Time is tissue. Then, you begin rapid fluid resuscitation with 30 milliliters per kilogram of crystalloid solution for patients with hypotension or a lactate level of 4 or higher. The goal is to restore intravascular volume and improve perfusion. If the patient's blood pressure does not respond to this fluid bolus, they are in septic shock. This is a key distinction. Septic shock is defined by persistent hypotension, requiring vasopressors to maintain a mean arterial pressure, or MAT, of 65 millimeters of mercury or greater, along with a high lactate level. The vasopressor of choice is norepinephrine. The exam will test your understanding of this progression. A common trick question involves a patient whose blood pressure momentarily improves with fluids, but then drops again. The answer is not more fluids indefinitely. It is to start vasopressors. A helpful mnemonic to remember the early warning signs is time, temperature either high or low, infection, known or suspected, mental decline such as confusion or drowsiness, and extremely ill, expressing severe pain or general malaise. In terms of nursing management, your responsibilities include monitoring the response to therapy. This means tracking for a decreasing lactate level, improving blood pressure, and ensuring adequate urine output, which should be greater than 0.5 milliliters per kilogram per hour. This demonstrates that your interventions are working and perfusion to the kidneys is being restored. You also have to consider source control, which means eliminating the origin of the infection, such as removing an infected central line or draining an abscess. Mastering the rapid identification of at-risk patients and executing the precise sequence of the Hour 1 bundle is a high-yield topic for the NCLEX.